Maurizio. And first I disclose that I'm a consultant for Pulsion Medical Systems. First of all, what is the problem with the fluid administration if we don't speak about the type of fluid? I think that I will try to convince you that it's a very important issue because we have two important problems with the topic of fluid administration. The first one is that there is today a huge amount of evidence that fluid overload increases mortality, and especially in septic patients and ARDS patients. Among many studies, just a few slides. You know the large SERP cohort, more than 3,000 patients with this result of multivariate analysis. The cumulative fluid balance independently predicted mortality in this large population of septic patients. Fluid overload increases mortality during sepsis, and we should avoid fluid overload. Among many studies, this one we conducted last year with Mathieu Josviak and Jean-Louis Teboul, and you see that in these ARDS patients, again, the mean cumulative fluid balance predicted mortality independently from the other severity indices. Fluid overload increases mortality during ARDS. And I think that today, if we want to start to speak about fluid responsiveness, the first and perhaps the main important message should be this one: fluid overload is deleterious in septic and ARDS patients. The second problem is that all patients do not respond to fluid administration, and this comes from physiology. And you know the cardiac function curve between stroke volume and cardiac preload. When you give fluid to a patient, of course you increase the cardiac preload, but in fact you expect that it will eventually increase stroke volume. The problem is that you know that there is not one cardiac function curve, but a family of curves, and the slope depends on the cardiac contractility, on the systolic function. And so this is why the same volume expansion with the same increase in cardiac preload could correspond to a significant or negligible increase in stroke volume and cardiac output. In other words, all patients do not respond to fluid administration. And this is, of course, something we have to do with, and you clearly understand from these two messages that, logically, we should predict fluid responsiveness in order to avoid fluid overload. How to do? You also know, likely, because it's today clearly demonstrated that the wrong way to do is to use the central venous pressure. And the main reason why CVP is not a reliable predictor of fluid responsiveness is, again, physiology. And it's clear from this picture here that a given value of CVP, for instance, I don't know, 10 or 14, is not an indicator of fluid responsiveness just because you don't know the slope of the cardiac function curve. And so this strategy, CVP is low, I should give fluid, CVP is high, I should not give fluid, this strategy is actually not the good one. CVP does not predict fluid responsiveness, and it comes from physiology. And today, I told you there is a lot of evidence about this. Many of these studies were aggregated in this meta-analysis by Maric and Cavalazzi, and the conclusions is clear. There is no data today to support the widespread practice of using CVP to guide fluid therapy. This approach to fluid resuscitation should be abundant. A given value of preload is not indicative of fluid responsiveness. Preload is not preload responsiveness. And of course, it's true with CVP, but any static marker of cardiac preload, the LV end-diastolic volume, the flow time corrected with the esophageal Doppler, etc. So then, how to do? And here we come to the concept of functional hemodynamic monitoring. In fact, what are we speaking about? In fact, it's just something that allows to test the cardiac function curve at the bedside. And the principle is very simple. Change preload in any way and then observe the resulting changes in cardiac output. And if the patient responds to the changes in preload by changes in cardiac output, it means that he's likely preload responsive. How to do? The first and perhaps the most intuitive way is to use the classical fluid challenge. What are we speaking? And you know that it is recommended, for instance, in the Surviving Sepsis campaign. What are we speaking about? Give a certain amount of fluid and see what happens. For instance, you give 500 milliliters of saline, and if cardiac output increases, you start again and you go on with fluid administration until the last 500 mLs that will not increase cardiac output anymore, and then you stop fluid administration. Actually, it allows to test the cardiac function curve at the bedside. That's obvious. But my main problem with the classical fluid challenge is this one. If you think about a patient with a septic shock and an ARDS during the first day, you will agree with me that there will be perhaps 4 episodes of hypertension. And so it means that at the end of the day, this patient will have received more than perhaps 2,000 milliliters of saline, while it did not increase cardiac output at all. This is obviously fluid overload. And so that's why I believe that the classical fluid challenge may be dangerous in such patients, not in the operating theater or perhaps in patients without lung impairment, but in patients in ICU, complex patients with ERDS, then I think that this is dangerous. And so in such instances, we should need something that would allow to predict fluid responsiveness without administering any drop of fluid. The first way to do, as you know, is to use the respiratory variation of hemodynamic signals like pulse pressure variation. 2 important messages today concerning PPV. The first one is that I think that there is no doubt today that it is a reliable way to predict fluid responsiveness. Look, for instance, this systematic review of the literature by Marik again, and in almost 700 of patients, you see that the area under the accumulated drug curve was good. It is reliable. But the second message, and perhaps for the practice, it's the most important message, is that PPV cannot be used in some circumstances. And we must always keep it in mind at the bedside. First, in case of spontaneous breathing activity, even in ventilated patients. Second, in case of cardiac arrhythmias, even with extrasystoles. Third, in case of ERDS with a low heart volume and a low lung compliance. Also in case of open chest surgery and in case of a very high respiratory rate. The problem is that you agree with me that especially the 3 first instances are frequent, and especially in the ICU patients. And I think that in my practice, it's almost 80% of patients in whom we could not use PPV to predict fluid responsiveness. Then how to do? I will speak about 3 different alternatives. The first one is the end-expiratory occlusion test. If you do not know about this test, I would suggest you to try it because it's very easy to perform. The principle is also very simple. When a patient is ventilated under mechanical ventilation, each insufflation tends to impede the venous return, tends to decrease the cardiac preload cyclically. And so it means that if you interrupt mechanical ventilation at end expiration, just like for measuring the intrinsic PEEP, then you stop this cyclic impediment in venous return, meaning that you allow the cardiac preload to increase. And so, in fact, this short end expiratory occlusion induces a preload challenge. Then just observe the changes, the resulting changes on stroke volume and cardiac output. The point here is that it's much more easy to use if you have a continuous measurement of cardiac output. And for instance, here in this example, cardiac output, cardiac index measured by pulse counter analysis that Chris Hoffer spoke about just before. We will stop mechanical ventilation at end expiration, and you see the value of cardiac index increases progressively, meaning that this patient responds to the increase in preload by a significant increase in cardiac output, and that this patient is fluid responsive. An important point is that the duration of the hold must be 15 seconds. It must be long enough to allow the cardiac preload increase to transit through the pulmonary circulation. And in this study, and we confirm this later, the cutoff value was a 5% increase in the continuous measure of cardiac index. The first message is that it's very easy to perform, and I think in a ventilated patient, of course, and again, this is the reason why you should perhaps test it, then we must also bear in mind that it's not possible to use it in some circumstances where it is limited. It could be related to the PEEP level, because you reduce the airway pressure to the PEEP level, but actually it's not the case. This is at least what we suggested in this study with Serena Silva and Jean-Louis Teboul also. And we showed that if we changed PEEP from 5 to 14 centimeters of water, the area under the RAC curve were the same. It means that in this range of PEEP levels, the test remains reliable. No, I think that the main limitation is that it cannot be used in non-intubated patients, but also that it cannot be used in patients who cannot sustain an expiratory hold. And it's a 15 seconds hold, and so it's better to use it in mild sedated patients. Of course, also, I showed you that it's much easier to perform if you have a continuous measurement of cardiac output. Anyway, you can use it even in case of, for instance, cardiac arrhythmias, even spontaneous breathing, provided again that the patient is able to tolerate this end expiratory occlusion. The second alternative is the passive leg raising test, and of course you know about this test. You know that transferring a patient from this semi-recumbent position, the semi-recumbent position is important, to the horizontal trunk position allows to transfer some fluid and some blood from the legs, but also from the splanchnic, the large splanchnic compartment, toward the cardiac cavities. Again, not EEO, I'm sorry, but passive leg raising is a preload challenge. And like in this patient, we described it some years ago with Jean-Louis Teboul. In this patient, for instance, who is going to respond to volume expansion by a significant increase in cardiac preload, the preload challenge induced by passive leg raising was a predictor of fluid responsiveness. The first message is that there is today quite a significant amount of evidence that it is reliable. And many of the studies have been even reviewed in this meta-analysis with a large area under the RAC curve. The second message, and very important message, is that passive leg raising requires to measure cardiac output. If you only measure the arterial pressure, you have some false negatives, meaning that you perform the test, but the arterial pulse pressure doesn't change while the patient is a responder. And I think that this is the main limitation of the passive leg raising test. You need a real-time measurement of cardiac output. Nevertheless, we recently developed a way likely to assess the effects of the passive leg raising non-invasively, because we showed that it was able to assess the effects of passive leg raising just with the measurement of end-tidal CO2. You know that provided that the patient has stable ventilation, then the changes in EtCO2 reflect the changes in cardiac output, and like in this patient, the effects of volume expansion could be predicted by the effects of passive leg raising on end-tidal CO2, and perhaps it could be a reliable way to perform it non-invasively, much better than with the changes in pulse pressure during the PLR. A third alternative may be to use the mini-fluid challenge. And you know that it was developed by some French colleagues, Laurent Muller and Jean-Yves Lefranc. The principle is simple. They just administered 100 milliliter of fluid. And you see that it was able to detect the changes induced by a further fluid administration. My main problem with this mini fluid challenge is this one. You see that it's only a small volume of fluid that's able only to induce small changes in the velocity time integral that must be detected with echocardiography. And you know that the reliability of echocardiography and the precision of echocardiography is not really perfect. And so I think that the main limitation is that it requires a very precise technique to measure cardiac output. Whether it could be better with some other more precise technique should be tested and further validated. The last message in 2 slides is this one. I think that if you give fluid to your patient, you should assess the effectiveness of fluid administration. If you give an antibiotic, you just check the body temperature to know whether it was effective or not. How to do? And in fact, here there is a very practical question. Should I measure cardiac output or not? And perhaps this will also complete the response of Chris Hoffer to your question, Anders. Do I need to measure cardiac output, or should I use only the simple arterial pressure? And in this study, we tested whether to assess the effects of fluid, we could rely on the simple arterial pressure, or if we would need any device to measure cardiac output. And we showed that you see that there was a correlation between the changes in the true cardiac index and the changes in pulse pressure, and more importantly, you see that the changes in cardiac index allowed to classify patients between responders and non-responders. What did happen if we looked at the changes in pulse pressure? We had this repetition of patients with a significant proportion of false negatives, meaning that we gave fluid, pulse pressure did not change, while cardiac output in fact increased. And so it emphasizes that arterial pressure is only a rough estimate of cardiac output, and monitoring fluid therapy without a cardiac output measurement is like monitoring antibiotherapy without a thermometer. And I think the last important message is likely that if we want to have a precise assessment of the response to fluid administration, and especially in complex patients, we need a direct measurement of cardiac output. Thank you very much for your attention.